How many are in the class, in the group, in the year, in this particular subject? 70? And you get 10, wow. People don't go to lectures much these days, do they? It's fun. I think you always gain more from actually being there than listening to it, personally, but I suppose you've got pretty heavy schedule, so I suppose it's easier that way, but to just listen to it on whenever you can, rather than during a lecture. Has it changed since COVID? Less people coming to lectures now than, or is it about the same?
I don't know.
You don't, yeah, well, no, you weren't. Yeah, but of course. Well, you're third year. Oh, yeah, no. Of course, you've just come through COVID, haven't you? You wouldn't know before. No, I'm just trying to work out whether or not, because people got so used to listening to lectures online, that they just prefer to do that now than actually come in. But then I used to give some lectures at Murdoch, and I think there were about 80 or 90 in the course, and you're lucky to get 4 in the audience. So probably that was years before COVID. So probably, I think ever since they started recording them, I think people now just listen to them online, podcasts. And do any of you guys listen to? I've been told that some people listen to it at double the speed. Do you do that? I think you miss an awful lot doing that, but everything will get done quicker, I suppose. Waiting for it to tick over to 1 minute past, just to make sure this thing's all on. All right, well, good morning, everyone. We're going to continue on where we left off last time in pharmacology, clinical pharmacology 1, to now do clinical pharmacology 2. And just to remind you, we talked a little bit about drug discovery, and then we talked about therapeutics. And I just want to remind you that we talked about drugs and doses, and then we then talked about this absorption, distribution, metabolism, and excretion, leading to a particular drug that's left both in the blood system and in the tissues. And we can actually monitor it at this level, which was our therapeutic drug monitoring, which we talked about. And it's this drug level that then interacts with your target to either lead to a therapeutic response or, in some cases, toxicity. And we'll talk a bit about toxicity today. And the first part of this pathway was referred to as pharmacokinetics, and the second is pharmacodynamics. And then we talked about the therapeutic range and the importance of having a therapeutic range which is going to actually benefit people, the majority of people, but not overlap and be into the toxic range where you're going to have a lot of toxicity. And that the ideal dose then within the therapeutic range is defined as the target concentration. So that's where we sort of finished, and we talked about therapeutic drug monitoring. Now we're going to actually talk about using pharmacokinetics to actually guide drug dosing. And we're going to talk about two main things, estimating loading dose and then estimating and adjusting maintenance dose. We're then going to talk a little bit about adjusting dose to impaired renal hepatic drug elimination. We're just going to touch on that. And again, a very small amount on drugs with nonlinear elimination kinetics. This is really a big area and it's very complicated. And so, I'm not going to cover everything. So I think it's really important that you do go back to your literature and have a bit of read as well. It's also very complicated. Now, in the past, people have had to in exams, for example, have had to use calculations to work out what loading dose and maintenance doses are. You're not going to have to exactly this time. I suggest that you do learn about estimating loading dose because it's pretty simple, and I think you can all handle that one. But you're not expected to actually work to know how to calculate maintenance dose. But what we do want you to understand out of this is the relationship. We're going to be talking about lots of nomenclature that you probably may not have heard about. I'm going to want you to understand what they are and the relationship between them, but I don't expect you to actually calculate anything from that. And then the effect on renal hepatic drug elimination, if there's disease, has an impact on this maintenance dose, and Lexi will touch on that. And then at the end, we're going to talk very, very quickly about some clinical toxicology. I think you do toxicology at some point anyway, but we'll talk clinical. I'll just give you some examples. Now, this is a complicated area, and this is a really interesting website, if you want to take note of this, to go to. It's a pictorial introduction to clinical pharmacokinetics, and it's an interactive clinical pharmacology program. The good thing is you can change parameters and see how relationships change. I really recommend you having a look at it because it helps understand the relationships. And this is what I really want you to get, the relationships between different parameters, more so than being able to remember formula and do calculations. So what is the loading dose then? So the loading dose is larger than the standard dose. It's something you give at the beginning of drug therapy to quickly raise the blood level of the drug into the therapeutic area. It's used when the patient may be needing a large dose of drug to achieve an immediate effect, and there's no time to achieve the progressive drug accumulation. So you bang them with a heavy dose. Whereas the maintenance dose is one that continues to keep the drug at the desired therapeutic range. It's generally used after the loading dose, but for many drugs, the patient can receive the maintenance dose at the beginning of therapy and then throughout the therapy as well. So it depends on how quickly you need the response or the effectiveness of that particular drug. So calculating the loading dose. So let's think of this a closed situation. So if you give someone a dose immediately, and let's pretend that there's no distribution required, it's immediate, that the amount is going to be in the blood straight away. So we give a particular concentration of drug and we get an immediate hit at a maximum level. And then over time, you'll get elimination. So that will slowly then eliminate out of the system. And this follows a formula called loading dose equals the concentration at time 0 times by the volume of distribution. Now, the volume distribution is a really important term in kinetics. It's one of only two constants that never changes. So this is it. The volume of distribution is the sum of the central and the peripheral compartments. Remember last time we talked about this idea of central and peripheral compartments. It's really a theoretical value. The central compartments sort of represented the blood system, and then the peripheral compartments were the tissues, and that's where the actual effects occur. So if we sum those, this is what the volume of distribution is. And let's take it that it is actually a real value for now, and to do these calculations that we have to do. So the volume of distribution is actually worked out. It's actually already been determined by population averages. So what happens is that the drugs have been given in a high dose to somebody. They measure the concentration of that drug. They've looked at it over a whole population, and they come out with a particular number. And so to calculate then a particular dose, and this is really important for you to remember how to do this, the loading dose equals the concentration times 0 times by the volume of distribution. And we think about an example. My patient needs a blood concentration of gentamicin, and we need it to be at 10 milligrams per kilogram to treat a serious infection instantly. So the population average for gentamicin is, and we've been told this, is 0.8 litres per kilogram. And we have a patient who weighs 80 kilograms. So therefore, the volume of distribution for this drug for this patient is 0.8 litres per kilogram multiplied 80 kilograms equals 64 litres. Therefore, to calculate the dose that we need to give them, it's the initial dose that we require, which is 10 milligrams, times by the actual volume of distribution, which is 64 litres. Therefore, we have to give this patient 640 milligrams to achieve that particular concentration. So we're taking it, it's a closed system. Now, that's great. We've been told that the volume of distribution is 0.8 litres per kilogram. And as I said, it was determined by giving lots of people gentamicin, measuring it in their blood concentrations immediately, and then coming up to a value. But this is just a population average. It's not for that particular patient. So if you want to be more specific to obtain the actual volume of distribution of that patient, then what you just do is you give a dose, you measure in the concentration of that drug in the plasma after that first dose, and you can calculate it. So we know the dose that we give the patient, we know the concentration we want to achieve, we know the concentration because we measured it in the blood, and then therefore from that we can calculate for that particular person the volume of distribution. Okay? And it's important that at any point on that curve, that volume of distribution never changes. It never changes in an hour, in 2 hours, 4 hours, next day, next week, next year. It will always remain the same. Okay? So for that drug and that patient, that will be the volume of distribution. So it says here that the remaining amount, and also the remaining amount in the body at any particular time is called A in terms of milligrams, and it's a measure of any concentration at time t that you can measure, multiplied that volume of distribution. Never changes. Okay? And VD always remains constant. Remember that. VD never changes. Therefore, we can think of this as a relationship between the amount of drug in the body and the blood concentration. So that's okay for loading dose. What about calculating maintenance dose? Well, maintenance dose rate really is the elimination rate at a steady state. And that is the amount of drug that you put into the system equals the amount of drug that comes out of the system, or the velocity of elimination reaction, V. So at equilibrium, drug in equals drug out. The dose equals elimination, and it's usually talked about in milligrams per hour. And that makes sense. You give a drug, and over time, that drug will eventually all be eliminated. So it's equal. Therefore, when you talk about calculating maintenance dose, it's all about the elimination rate. Now, if we think of biological systems, they're very interesting, and we're talking here, and we've got in front of us the Michaelis-Menten elimination kinetics. This is for enzyme kinetics. But in biology, lots of these different calculations, or lots of these different equations, all are repeated in many times. And in fact, when we're talking about reaction rates with enzyme and enzyme clearance, it's exactly the same as with drugs. So we can superimpose that. There's a few little changes, but essentially the mechanism is the same. And this is the Michaelis-Menten elimination kinetics. So in this case, we're talking about ethanol. We're using an example. These are the actual rates of ethanol clearance, for example. And we're talking about a reaction rate. So this is how quickly it is reacted, and that we get a percentage of the maximum amount. And if we give various different concentrations of ethanol, we find that there is a very, very rapid interaction between the enzymes that break it down and the actual substance or substrate itself, until we get to a point up here on the curve where there is equilibrium being reached, or saturation. So the amount of enzyme that actually binds to the ethanol is finite. It doesn't increase. It's finite. And you get a point where you can't get any more, so it's saturated. So what happens then is it tails off to this asymptote, and it's a hyperbolic type reaction equation, and it doesn't then go back down again. You can't eliminate that particular amount of drug and calculate it until it goes back down, because at this point, no matter how much more you give, you're not going to get a faster reaction. It's not going to happen. It's reached its maximum. And this follows the Michaelis-Menten equation, where V, or the reaction rate, is equal to the maximum velocity, Vm, times by the concentration, over the concentration plus Km, which is very important, the Michaelis-Menten constant. And Michaelis-Menten constant is the concentration of drug where 50% of the Vmax is achieved. So you can see that here. And that's the Km value. In this case, it reaches about 0.15 grams per litre. Now this can be thought of, this particular first part, is almost being linear. It's a linear elimination. It's only when it gets up here it becomes non-linear. It's particularly linear when you think of the concentration of drug that we're using being much less than the Michaelis-Menten constant. And in fact, this is what happens in this area, which is called the first order elimination or linear pharmacokinetics, is what happens with most drugs. Nearly all drugs follow this particular elimination in this linear range, being first order elimination. And so if you think about it, if you come here, if you think when the concentration of drug is used as much less than the Km, it must be much less than the Km. Then V is proportional to the concentration. That is, the rate of drug eliminated is directly related to the concentration of drug, which is also known as the elimination rate constant. And if you look at this equation, V equals Vm times C over C plus Km, you can really think that if C, the concentration you're using, is a lot less, only when it's a lot less than the Michaelis-Menten constant, that it's really negligible. And that really you've got an equation which is approximating Vm times C over Km. And really what you're saying is that the velocity of elimination is equivalent or is in proportion to the concentration of drug. And if you look back at that previous, looking at that previous reaction here, and you can see that this is almost linear. This is confirmed if you measure, for example, two different concentrations of drug, and then you actually plot it, you'll find that it actually does form a linear, almost linear, because it's not quite, but almost linear, or pseudo-linear. It forms a straight line, and there's a direct relationship between V and C, and the actual concentration. And if you measure the slope of that, it'll always be consistent and always be constant. That slope is called the elimination rate constant, or Ke. It's the same for all drug concentrations, providing that the concentration you're looking at is much less than Km. So that's all great, and that was, for example, a preparation in a test tube, looking at some liver and looking at ethanol. But what about if we're talking about patients? What about clinically? Well, we can, like I said, make a couple of measurements, and we can actually calculate the change in concentration of the drug. So in a clinical application, V, which is the velocity of elimination reaction, is recognized as a change in the concentration over time. We can call that delta C. Or it's also known as the change in the amount in the body. So we can actually, if we bring in this constant of velocity of distribution, then delta A, or change in the amount in the body, is equal to the change in the concentration times by the volume of distribution. Now, Ke is another constant that, as a constant suggests, it remains the same all the way through. So the whole way on this elimination curve, the Ke is exactly the same. And we can measure various different points, and it would not change. But if we measure two particular points, we can calculate the change in concentration. And we can also use it to calculate, we can also use the any particular one point on here to calculate the delta C as well, because we know that it's consistent with this Ke. So in blood, and so that's the one reaction, and if we talk about in blood, then the change in the amount of drug in the body, now is delta A, is equal to the same thing, Ke times Ct, but now we talk about the volume of distribution. And so we can measure the amount any time that remains in the body. So this brings in, so if we think about this in another way, we can also talk about, if we talk about drugs and drug dosing, this is all at time zero. We give a particular drug, call this, say D2 is the drug we give. We have this, this rate of elimination, doesn't change, exactly the same. If we double the dose, then the rate of elimination is still exactly the same, doesn't make any difference. Or if we halve the dose, it's exactly the same. And it shows that we've actually got a relationship here between different drugs. So dose 1 over dose 2 will equal to the same as the Cmax, which we know, 1 over Cmax 2, which equals C any particular time 1 over time 2. So it's always, that relationship is consistent because it all has the volume of distribution, the elimination constant is always the same. And this is the hallmarks of what they call first order or linear elimination. And we can actually change that around, and it works out exactly the same thing. So we've got a relationship now between the concentration at any particular time that you measure on this curve over the original starting dose. And that C1 over D1 will equal the same as C2 or D2, C3, D2, exactly the same. And this is called proportional linear. So when we start talking about different concentrations and measuring different concentrations, we talked last time about area under the concentration time curve. And in fact, the sum of all the concentrations that you measure equals the area under the concentration time curve. And therefore, all AUCs, just like we saw before with D1 over C1, etc., equals proportionally the same. All AUCs are also going to be proportionally the same. So no matter what drug dose you give, the AUCs are proportionally exactly the same. And we can actually use drug monitoring that we did before, therapeutic drug monitoring, to look at this. So we can measure a particular CT, a concentration at any particular time. We usually do it at pre-dose though. Or we can measure concentration at several time points, and we can estimate the area under the curve. And the area under the curve is really the volume or the amount of drug that's available for a reaction. Then we can adjust the dose linearly to get the target concentration, or the AUC. So we've talked about a single dose examples to demonstrate these relationships, but they equally apply if you're doing repeating dosing or continuing fusion dosing. Everything always stays the same. Proportions always stay exactly the same. And AUCs always remain exactly the same, as in proportionally the same. So what about clearance? Now clearance, this is really important to remember, the difference between clearance and elimination. Clearance is the volume of plasma that all drug molecules need to be removed per unit of time to achieve elimination of drug from the body. Memorize it, okay? You need to know the difference. What is clearance versus elimination? Clearance is the volume of plasma all drug molecules need to be removed per unit of time to achieve elimination of drug from the body. It can be a bit confusing sometimes, so it's really important to know that. And this is the calculations that we saw earlier. The change in concentration equals this Ke times any particular CT value, any concentration at a particular time. And likewise, when we talk about patients or blood measurements, we can look at the amount or change in the amount of drug in the body is equal to the same thing, except now we multiply by this volume of distribution. And we can rearrange this particular formula to now have the change in the amount in the body over a particular concentration at a time equals Ke times volume of distribution, meaning that the amount eliminated at any particular moment is always in a fixed relationship to the drug concentration at that moment. And therefore, complete elimination of the drug over time from a volume of blood was going to equal Ke times Vd, and that is actually what we call clearance. So clearance then is just that relationship, which is Ke times Vd. And the important thing here is we've now eliminated any association with the concentration of that original drug, because it doesn't matter what the concentration of the drug is. If we know the Ke and we know the Vd, or the elimination constant and the distribution, velocity of distribution, we can actually measure clearance. And we measure it in terms of litres per hour. So how do we do this clinically? Well, we can give a loading dose to a patient. We can measure C0, so the initial concentration immediately after we've given it, taking it that it's being distributed immediately. That is concentration at T, 0. And we can calculate the volume of distribution. We can then measure the concentration at multiple times, and we can calculate the elimination constant. And therefore, if we can do that, we can measure the clearance rate, Ke times Vd. And we can also measure drug, so this is important too. So this is all in blood we're talking about. And we can measure the clearance rate in blood, but we can also measure the clearance rate through excretion in the urine. You can measure the amount of drug in urine at any particular time, and it works exactly the same way. And the important thing here is that one of the biggest problems in trying to look at dosing in a patient and maintenance dosing is whether or not the patient has any disease, particularly disease in their organs of elimination, being the kidney or the liver. And if we can look at excretion of drug, knowing what we should expect to see, we can determine whether or not the patient's got kidney problems, whether it's actually got the functional, the kidneys are functioning properly. And then we have to adjust the dose appropriately if they are not eliminating the drug as we expect it to do. Now that's great with kidneys. It's much, much harder to do that with liver, because with liver elimination, it's not proportional. And so the only way we can measure liver disease really and the effect is to keep measuring different doses of drugs over different times. And you've got to keep a very close eye on anyone who's got liver disease as to what dose drugs in their system at any particular time. But it's easier to do it through kidney when it's completely eliminated through kidneys, which some drugs are. And this is just to show you what happens if renal function is impaired as an example. So we talk about a range or drug range, and we give a drug to a patient, and then it comes down to a point where it's at the bottom of that range that we don't want it to be any lower than, and we'll give them another dose, and it'll go back up again, and it'll be eliminated, and it'll go back up, and it'll be eliminated, etc. And that's normal. And we're giving an example here of the clearance rate as being 120 mils per minute, and that the half-life of this drug is, say, 3 hours. So every 3 hours we'd give it another dose. Now, what happens if the kidneys are impaired? Well, we give it the first dose, but it's not completely cleared. And then, or at least the half-life's not completely cleared. And then we give another dose. So now it's a little bit above that particular threshold of the therapeutic range, and it drops, but it doesn't get cleared. We give another dose, and it comes higher again. Another dose comes higher again. And now you can see that we're now entering this toxic zone. It's no longer in the therapeutic range. It's now coming into the toxic range. So we don't want to keep giving them doses like that. It's going to get higher and higher and higher and more toxic. So we have to adjust our dosing so that it'll come back down to within the therapeutic range. And this is just an example. So as I said here, the clearance rate was 120 ml per minute, half-life of 3 hours. Say the clearance rate we calculate now as being 60 ml per minute. So the half-life is doubled, and it's now 6 hours. So therefore, the AUC, area under the curve, is also doubled. So we have to now half the rate that we give that particular patient. Okay? We don't give it the same dose. Otherwise, we're going to have toxicity. Now, we talked about this linear area, and that's, like I said, most drugs fall under that. But there are some drugs that really don't, and that they actually come up here above this pseudo-linear range. And we can think of it, if we think of the Michaelis-Menten reaction equation again, let's look at it a bit differently. So now we've got the concentration of the drug, which is not being cleared because it's already saturated, when it's much larger than Km. In this case, in the linear range, the drug concentration was much lower than Km. Now it's much higher. And there's not a lot of drugs that do this, but alcohol is one of them. So now we can change this equation a bit, where it was Vm times C over C plus Km. Now your Km is really, really, really small, and your drug concentration is getting large. And so we can rearrange that, and so knock out the Km, because it's really irrelevant, and so it's Vm times by C over C. And so, in other words, if you can cancel out those C's, the rate of reaction is actually equal to the Vmax. And this is what you've actually seen. So basically, this is it. The Vmax is the rate of reaction at this high level up here. And so it's the same as saying that the elimination rate, or the change in concentration, will be at a fixed maximum, not at a rate that is determined by the concentration. It doesn't matter what the concentration is, it'll always be at Vmax. So unlike this zone here, this sort of pseudo-linear range, where we have clearance, although it doesn't look like linear, but that's what it is, a linear clearance, we now have a non-linear clearance, which looks linear. It's a bit strange, really, but it's not. And so we now have to think of it very differently, and this is all a function of time. And what I mean by this, so if we measure a particular drug at a particular concentration, say at concentration at time 0, so it's all relation to time now. So a change in concentration over the concentration at time 0 times by the volume of distribution will equal your clearance. This is called non-linear zero order or saturable elimination. And that's great. But as we come down the order here, the change in concentration at 10, and this is the example we've used, starting point at C0 is 10, times by the volume distribution equals clearance. But as we come down, the change in concentration will now be at, say, 9, or at 8, or at 7, or at 6. So the denominator is changing as we go through. So now we've not got a linear relationship because it keeps changing. And therefore, the clearance rate is also going to change. Whereas the clearance rate was consistent when it was in linear form, now the clearance rate is not linear and it is changing. And that means then that that you'll get longer half-lives at higher concentrations than at lower concentrations, and the concentration is dependent, or so to say that you've got concentration-dependent clearance. So clearance will be dependent on the concentration, and that you've got a disproportionate, an increased amount of concentration with an increased amount of drug that you give them. So it is no longer proportional. And therefore, to keep a maintenance dose, to adjust a maintenance dose, you have to give less than the proportional amount that you would have given if it was in that linear range. So it changes. All right, so that's just talked about kinetics. Now, it is complicated, and I do suggest that you look at that website I've given you, which explains it and actually allows you to put some values in there. You can see how things change. It's all about the relationships. What do each of these things mean? What is the velocity of distribution? What is the elimination constant? That's what we need you to know, and how they relate to each other. Okay, but they're not going to be expected to calculate anything. So let's talk about now, just check how we're going time. So let's talk about now therapeutics versus poisoning. And it's really exactly the same concept. So we use exactly the same pathway that we did before. Instead of a drug now and a dose, we've got a toxin and a dose. Still goes through absorption, distribution, metabolism, excretion, exactly the same. And again, instead of a drug, we have a certain level of toxin in the blood and in the tissues. And that particular level of toxin will then interact with the target to lead, in this case, not therapeutic response, but leading to toxicity. And in fact, it was Paracelsus that said, what is there that is not a poison? And he's absolutely right. All things are poisons and nothing is not a poison, because it's only the dose that differentiates a poison from a remedy. Now, some things are toxins straight away, but all drugs can be toxins. It all depends on the dose you give it. And if you give too much, then it's all going to be toxic. So this is a very astute and very correct comment. Although he did it in German, this is translated to English. And I just wanted to mention that you would probably have all already talked about a P450 system of elimination. But drug interactions through the hepatic well, it's not just hepatic, but mainly drug do get cleared through the liver through P450 metabolism. So cytochrome P450, also known as P450s or CYPs, are a superfamily of enzymes that contain heme as a cofactor that mostly but not exclusively function as monooxygenases. In mammals, they oxidize steroids, fatty acids, and xenobiotics, important for the clearance of various compounds, as well as important in hormone synthesis and breakdown. But we're interested with regard to clearance of compounds. It is the main clearance mechanism in the liver. And drug interactions through the P450 metabolism occurs through either phase 1 or phase 2 reactions. Now, it's all about solubilization of a drug and clearance of a drug. So phase 1, it involves oxidation, hydroxylation, deamination, dealkylation, hydrolysis, etc. And the whole point of it is to increase the water solubility of that drug and to allow or facilitate phase 2 metabolism, which is all about clearance. And importantly, when we talk about the P450s, there's a family of them, there's a whole range of isoforms of them. There's families, subfamilies, and isoforms. And actually, that's how we actually determine which ones are important for different drugs. So different P450s will actually eliminate different types of drugs. And we'll refer to them as, so for example, we use CYP, so cytochrome P450, just abbreviated as CYP. And we'll talk about the family name, so it'll be CYP1, for example, and maybe it's A, so CYP1A, with isoform 2. And that'll be, that particular isoform is called CYP1 alpha A2. Or it might be over here, and it might be family 2, so it's CYP2 CYP3B6, for example, or CYP3A4 or whatever. And in fact, these human isoforms here are the main isoforms that basically clear 90% of most drugs from the liver. And so we get phase 1, and then we move down to phase 2. And this is where we get conjugation, mainly to glucuronide and sulfates, which what it does is actually further increases water solubility. So the whole P450 system is to metabolize a drug and to allow its elimination. Now, it wasn't originally meant, I think, for that when it was designed in the body. It was designed to actually eliminate different waste products in the body. But of course, it's exactly the same mechanism that we have for drugs. And this is just some examples here. This is the different isoenzymes of P450, the different ones here. Do not expect you to remember them and know what the drugs that they represent, that they clear. But these are the drugs that are cleared by the particular isoforms of these P450. Do not have to remember this. Just show you that each one has a different particular drug that's cleared by that particular isoform. So I want to give you some examples now of poisoning syndromes, also called toxidromes. And the important thing here is, so if you've got a patient comes into ED, for example, and they have particular characteristics, they show clinical signs, it's actually the clinician who can actually identify those signs and work out exactly what likely type of overdose that they've experienced. And it's sort of like pharmacology, there's pharmacology done backwards. So, for example, if you've received a stimulant, a patient comes in with having had an overdose of a stimulant, maybe amphetamine or cocaine, etc., then they'll experience certain characteristics, clinical characteristics. Tachycardia, hypertension, agitation, dilated pupils, seizures. Dilated pupils give this one away. So this will be a characteristic that the physician will identify and go, okay, likely to have a cocaine overdose or at least an amphetamine overdose, some sort of stimulant. Opioids, heroin, morphine, methadone, etc. They're usually drowsy, go into a coma. They have hypoventilation, hypo meaning they're not breathing. And in fact, the main effect of opioids of killing people is through its suppression of respiration. And classically, they have meiosis, which is tiny pupils, really tiny pupils. And that gives it away often. A sedative, benzodiazepines, alcohol, etc. They come in drowsy, maybe can go into a coma. They stagger, slurred speech, classic of alcohol, as some people probably know. Hyperventilation too, so they also have problems with breathing. What gives them away here is that they may have a sedative rather than an opioid, is that they don't have the tiny pupils, okay, that you would recognize. Cholinesterase inhibitors, which are often in insecticides, bradycardia, bronchoconstriction, small pupils, sweating, again, a different clinical expression. And antimuscarinics here, such as certain antidepressants, and particularly deadly nightshade berries. I don't even know where you get them, but anyway. Again, another characteristics, tachycardia, vasodilation, pyrexia, dilated pupils in this case. But the point I'm trying to make here is that a good clinician can actually identify in advance the likely type of drug family that the patient is going to be exposed to, what they've had an overdose in, and they can start treatment immediately. And then, wait for the blood test to come back to actually identify exactly what it is that they've received. So I'm just going to give you a few examples now of poisons with their pharmacological antidotes. I'm going to talk about paracetamol and N-acetylcysteine, talk about methanol and ethanol, opiates with naloxone, and anti-digoxin antibodies and anti-venom antibodies. So let's talk about paracetamol. Now this is a really, pretty safe drug really. You have to take really, really large amounts of it to become, to OD on it. And paracetamol basically is cleared through phase 2 elimination. It doesn't require phase 1 elimination by P450. And it's sulfated, it has a sulfated and glucuronide conjugates, and it's just eliminated through the kidneys. Easy, not a problem. However, if there are very, very large doses, and it has to be very, very large doses, then basically what happens is cytochrome P450 causes, in the presence of NADPH and oxygen, causes the formation of this intermediary radical. And this is called N-acetyl benzoquinone imine. And this radical is normally cleared through glutathione. So the body has glutathione, it can then, the radical will attack the glutathione and actually form this inert compound, which is then renally eliminated. Not a problem. However, if the levels are really, really high, we have a finite amount of glutathione in the body, as we saw before, and we talked about. So we can no longer get any more glutathione, and they're going to end up with a lot of these free radicals floating around, which tend to attack cell membranes, particularly in the liver. And you end up with hepatocytotoxicity, and this is the main cause of paracetamol-induced death. So how do we treat this then? Well, we want to create more glutathione. It's not so straightforward, but what we know is that glutathione is made up, it's a tripeptide, and it has this important component called cysteine. And it's the cysteine that's required to make glutathione to actually form this inert compound. And so what we have to do then is we've got to give them cysteine. Well, they tried giving cysteine, thinking that would solve the problem, but it's metabolized differently and it did not work. What they found is that if you give N-acetylcysteine, that this provides a substrate that does work well and increases the amount of glutathione that's made and helps eliminate the drug then through the kidneys and urine. So that's the approach for paracetamol toxicity. What about methanol poisoning? Well, it's not such a big problem here. Methanol has been used in some countries instead of alcohol, because it is an alcohol. And methanol itself is not really a major problem. It's the breakdown products of methanol which is the problem. So when methanol is acted upon by alcohol dehydrogenase, it forms formic acid. And formic acid causes a decrease in the pH in the blood, or acidosis, and it also inhibits mitochondrial respiration. So you don't get production of ATP. And so this is the problem, it's the formic acid. Now, formic acid only forms because of the alcohol dehydrogenase. So what we have to do then to stop this forming, if someone's had methanol, is to block alcohol dehydrogenase. And we do that because we give it another substrate. So the other chemical that actually uses alcohol dehydrogenate is ethanol. And so we have to give ethanol to counteract the effects of the methanol. And we use it about 0.2% in the blood, which is 4 times the concentration of the alcohol driving limit. And if we give that, it now acts as a competitive inhibitor by blocking the amount, saturating the alcohol dehydrogenase. It binds to the ethanol and is cleared, and the methanol does not form formic acid anymore. Now, you've still got the methanol around, so you've got to get rid of the methanol. And the way they do this while the alcohol is being given is they use blood dialysis to basically clear the methanol from the system. So ethanol completely inhibits the oxidation to formic acid, and then the dialysis removes the methanol. And that's how we treat methanol poisoning. So what about other examples? Opiates. Now, an opiate, or an opioid, is an analgesic, but it also is a lethal intoxicant, and it all works through the mu opioid receptor. So it's an agonist of the mu opioid receptor. And opioids act on the central nervous system to suppress respiration, as I mentioned before. So that's how it kills you. If you do not get treated very rapidly, you will stop breathing. Now, the inhibitor that they use against the opiates is naloxone, which is also a mu opioid receptor antagonist, which is a mu receptor antagonist. And you can tell, this is morphine, so one of the opioids, and you can look at the structure of it, and you can see naloxone is very, very similar structure. So it basically is an antagonist. It just works, it binds to the receptor and blocks morphine. But this doesn't have any functional role itself. It's inert. So it just basically blocks morphine from actually working. And it's given intravenously because it actually has to get there quickly. You need to get it in there quickly. But the problem is and it rapidly displaces the opioids. The problem with it is it's rapidly cleared from the body. And so after about 20 minutes, the intoxication can resume. So they have to keep giving the naloxone until the morphine is slowly eliminated from the body. So that's how we deal with opioids. And that's all the opioids, not just morphine, it's just an example. And then another example is using antibodies. So specific antibodies that are raised against an intoxicant, for example, can be also a pharmacological antidote. So, for example, digoxin, which is the drug, which is the toxic chemical, you use the anti-digoxin antibodies. Venoms, snakes, spiders, etc., in this case box jellyfish. Again, once we know what the particular one is, we can get the anti-venom. So it's just literally an antibody that will then block that particular venom. So you think of this, this is still a pharmacological antidote. It's not a drug as such, but it works through a different mechanism, but it's still an antidote. So we've talked about then today about how we can calculate both loading doses and maintenance doses. What you need to understand, I reiterate that you need to understand how to calculate a loading dose, not how to calculate a maintenance dose. It's a simple equation. And you need to understand the relationships with maintenance dose between the different things such as the volume of distribution, the elimination constants. And you also need to know the difference between clearance and elimination. Okay, it's really important. And then, some examples which will be useful to learn one or two of those examples as a toxin versus an antidote. Has anyone got any questions that you'd particularly like to ask? If you want to, feel free to come up front and you can always ask. I'll see if I can try and answer it for you. All right, thanks so much. And that finishes the two lectures on clinical pharmacology. Don't worry. Yeah.
I found it interesting that you treat methanol poisoning
with ethanol. Well, it's just literally to replace it. Yeah, they're going to be very sick with ethanol. Although, let's be honest, 0.2, it's not going to kill them. But
it's not. So, I mean, is that because the product of methanol metabolism, formic acid, is significantly worse than the product of alcohol?
Oh, yeah, absolutely.
So you just sort of say they tried to get drunk via methanol, but we'll just get them
drunk with ethanol instead. Well, they're going to be very, very sick with methanol.
Yeah.
And so effectively you just basically put something else there. But I mean, of course, you give them the ethanol to prevent the formic acid forming, and then you get them on dialysis, blood dialysis straight away to clear it.
Cool.
And then you can drop the dose.
Do we need to know like how to calculate, like there will be
Only the original dose, the loading dose, yes,
okay.
but not maintenance dose, no.
So but I just need to know the equations.
So the loading dose is equal to the concentration of the drug at time 0 multiplied by the volume of distribution which is given to you. And so if you want to measure, so basically that's how you calculate it. So you know the concentration at time 0 that you want to get to. You know the volume of distribution because you'll be told it. You work out the volume of distribution for the patient by measuring that constant, which will be per kilogram, and you multiply that by the weight of the patient. So you know your volume of distribution, and therefore you can then calculate your loading dose on the basis of that. So, and that the formulas are there. So it's just loading dose equals concentration at time 0, multiply the volume of distribution. That's it. Okay, I mean yeah. The other, it gets really, really difficult. I mean, and you may do calculations of maintenance doses in pracs. I don't know. They used to do some pracs where you did that, and it's all about the elimination basically, or the clearance. So you work out what the clearance is, and then you can then work out what you've got to put back into the actual patient to, that's been cleared. But you don't have to calculate it. I don't expect you to have to calculate it.
But I need to know that.
But you know how to calculate the loading dose. Yes, that's important.
All right, thank you.
Yeah. Well, it might be. I mean, I don't know. There may be a question. But that's the only one that there would be a question on. There would not be anything about maintenance dose.
Okay, so
Just understand the relationship, what the different things are.
But there's a possibility that the loading dose question might come up.
Well, if anything does, that's the only thing that would. Yeah.
All right,
Yeah.
thank you.
Oh, hi. I'm just wondering for the reaction rate here. Is it the same as elimination rate?
So yes, so it's the rate of reaction. Yes, so that is the elimination rate,
Okay.
not the clearance rate, but elimination rate.
Okay, so they're
Okay.
at an equilibrium, like when the
Yeah.
drug in and drug out.
Yeah, but that's clearance. So clearance, remember, is the amount of drug that's cleared from the blood over a particular period of time, whereas elimination is just the amount that's cleared.
Oh, okay.
Okay, so that's, yeah.
So does this equation apply like throughout this?
No, it only applies, well, it does apply to the whole thing, but we're worried about this initial bit at the bottom here. That's why you change, and you can actually eliminate the C, because C, when it's much smaller than the Michaelis-Menten constant, is going to be so small it's irrelevant. And that's why we talk about the relationship then between the Vmax, or the elimination, the rate of reaction, and the concentration. So the bigger the amount, the more it's going to be eliminated.
Oh, I see. That's why we call it like a linear.
That's why it's linear, because it's almost a straight line.
Yeah.
And then it peters, and then it starts going to a hyperbola, because then you're reaching your saturation. You cannot clear it anymore. But most drugs are cleared by phase 1 reactions, or in that linear phase, and so it's taken as being linear. We work it out as linear, but only when the concentration of the drug that you're putting in or you're looking at is much lower than the Km. When it's much higher and comes up here, then it's no longer in that linear phase. Okay, I really recommend you going to that website.
Yeah, I will.
It's really good. It's simple, but what it does is it lets you change some values. And by changing values, you can see the relationship. And it makes a lot of sense.
It's kind of abstract from the paper, but I think it would be more...
Yeah, it is a bit more abstract, but it's actually really... What's really important for you guys is really just to understand concepts, okay? I mean, if you were going to work as a pharmacist, you'd need to know this stuff, okay? Or you've got clinical medicine, you need to know it. But you guys don't need to. What are more important is to know the relationship between things. And so that's what, as one thing goes up, how does it affect something else? As you increase concentration of drug, you increase the elimination. But it all falls on a line of constant. So, that elimination constant will remain the same. Volume of distribution will remain the same. You need to know the relationships between them. That's all you need to know. That's really what's most important. It is difficult, I must admit, it's not easy to follow. And it can get quite complicated. And we can get into, if you want to look at it properly, there's lots of mathematical equations to actually calculate things. And I looked at them and thought, no, there's